One of the themes that I've had through my first year here at the Commission on Excellence and Innovation in Health, otherwise known as CEIH, is that if something isn't measured, there actually isn't a problem able to be identified. Our first job was to appoint a steering committee, and I was very pleased that we were able to get a broad composition for that network. So the surgical network identified a few key priorities to work on. The first one, we in real time know how long people and patients are waiting from the time their GP asks them to be seen to the time they're actually seen in outpatients. Number two, we thought that there was probably a lot more work we could do in the area of what we wanted to call optimised pre-surgical care. It's a significant thing to undergo a surgical procedure, so we should get the patient in the best state that they can be to undergo that procedure. It will actually make the surgery easier for the surgeon, it will make it safer for the patient, and it will make it less expensive for society. We know that it is a long time that patients are sitting waiting there to be seen, so we should use that time to try and start optimising patients. Not all of those patients are going to go on to having surgery, but if we're able to address some of their key medical issues, we've improved their health. And we'll be looking at things like alcohol intake, smoking, people who are overweight or undernourished, people who are iron deficient, all these sorts of things we'll be trying to improve and optimise so that patients, when they come to have their operation, will actually be in a better state to do well. The third thing that we've been looking at is their emergency surgery workload. There is a clear mismatch between the emergency surgery capacity and the emergency surgery demand. We've actually achieved, for the first time ever, to get all of the surgical directors into one room and actually to discuss and agree on definitions surrounding emergency surgery. It's the first time that we've actually been able to get people to say what is an emergency operation, what's an urgent operation, what's a deferred operation, and agree on those definitions. We've also, through the incredible informatics section here at CEIH, been able to access data through the ORMA system, and therefore we've actually now been able to formulate a statewide picture of the problem and the mismatch between capacity and demand for emergency surgery. So we first of all wanted to prove that there was a problem between capacity and demand for emergency surgery. We've proven that. The next thing we wanted to show was how big is this problem? The third thing is obviously how do we try and rectify that problem? That's where we need to bring more people in, more minds, brainstorm and try and work out a way that we can improve the throughput of our emergency surgical patients. One of the really good things about the Commission is the clinical informatics section. They really have an incredible handle on how to get hold of data, where you go to look for it, and then how to work with it, how to analyse it, and what it means. I'm hoping that we'll then be able to feed that back and get some of this cross-network collaboration happening.